All right, I think we can get things started. Hello, everyone. My name is Julia Resnick, and I'm Director of Strategic Initiatives here at the American Hospital Association. In my role, my portfolio includes our association's work on maternal and child health. And through our Better Health for Mothers and Babies initiative, we are working with healthcare organizations from across the country to promote strategies that will lead to more equitable birth outcomes and reduce maternal morbidity and mortality. That is why I'm so excited to be here with all of you today to moderate today's sponsored webinar, Protecting Mothers, Key Takeaways from the 2024 Maternal Mortality and Morbidity Prevention Report. We're extremely honored to have Relias sponsor and lead this presentation and discussion today. They've been a great partner for the AHA, and we appreciate their leadership and work they've done in this important area. Before we get started, just a few rules of engagement to highlight. You can access audio by listening in through your computer speakers or through your phone. Please note that you are in a listen-only mode. If you're having any issues, you should be able to access the toolbar at the bottom of your screen to switch to either phone audio or computer audio. This webinar is also being recorded and will be made available on our website. We shared the slides via email prior to this webinar. Throughout the webinar, if you have any questions for our speaker, please enter them in the Q&A pod, which you will find at the bottom of your screen in the Zoom toolbar. I will do a moderated Q&A session at the end with Laura. If you have any technical questions or comments in general, feel free to use the chat pod, but please note that all our participants on the webinar can view the chat pod, but it will not be included in the recording. Finally, after our webinar is over today, we'll have an evaluation that will pop up on your browser. We would really appreciate your filling that out because we value your feedback, so please take that moment to complete it. With that, it's time to turn to today's fantastic speaker. We have Lora Sparkman, who is Partner of Clinical Solutions for Patient Safety and Quality at Relias. Lora provides internal and external consulting, thought leadership, and strategic guidance on the use and optimization of Relias clinical solutions related to improving patient safety and creating high reliability in some of the highest risk areas in healthcare, like obstetrics and the emergency department, as well as other clinical areas within the acute setting. Lora, I'm going to turn it over to you.
Thank you so much, Julia, and welcome everybody. I just want to thank everybody for registering for this webinar, this session, and I thank AHA for our partnership. It really gives Relias an opportunity to engage with more of healthcare leaders and frontline clinical team members on some really important topics like the topic today. But just a little note about Relias and our mission. Our goal is really to measurably improve the lives of the most vulnerable members of society and those who care for them. One of the key hallmarks about Relias, we are a learning and technology company, but one of our key focus areas is around workforce readiness. So we work really hard to provide accredited education content across the care continuum, nurses, providers, mid-levels, advanced practice, clinicians, certified nurse aides, etc. You name it in the clinical domain. We have that content for you to maintain your licensure, to grow your licensure, and even through our nurse.com, we have a community for you and your area of focus. So with that, I want to kind of jump into this. I wanted to set some context around this topic prior to jumping right into the maternal mortality and morbidity prevention report, which is to kind of set the stage. Many of you may know this, but I was recently speaking at the AWAN convention. And for those that don't know, that is the Association for Women's Health, Neonatal and Obstetric Nurses. We had a room of well over 200 frontline clinicians at that session that we hosted and spoke at. But one of the key things I asked the audience, which is, some very specific questions, like how many of you are aware of the maternal mortality rate and where we are as a country? And I was a little surprised at how little people raised their hand and said they were aware. So I'm always going to continue to share this information wherever I can. So you can see this slide represents the most recent and current data of the maternal mortality rate in the United States ending in 2022. These are the kind of the official data pieces. You see the blip from 2020 to and coming down right after 2021. Yes, that is likely due to COVID. That's what all the experts are saying nationally who are looking at this data. But it still doesn't change the fact that the US has the highest maternal mortality rate than any first world developed country. And that's still not okay. We still have a lot of work to do as an organization. So if you think about it this way, approximately 22 maternal deaths for every 100,000 lives. And some of these other countries have, less than 5 or 2. And so we have a lot of work to do. And then from the Commonwealth, report that came out in June, I would direct you to that report as it provides some additional detail around that. In addition, we know that Black women die at a higher rate than white women in other races, almost 2 to 3 times higher. But even when we had that data come down, it still shows that the difference between Black and brown women and white women is still 2 to 3 times higher of a mortality rate. And so that speaks to a lot of our culture, our approach to healthcare, the disparities and racism that exist in the United States. In addition, I also wanted to say this is something I've been following in my career and been focused on since 2025. I had some time at a very large health system. We were working across 62 hospitals in 32 different states on how to improve perinatal safety. And again, it's a team sport. It's physicians, nurses, midwives, leadership in hospitals and health systems and the community. And we're going to talk more about that. But since the data started surfacing in 2015 that the US actually had a maternal mortality issue compared to other countries, our country has gone to work. So I do want to say this White House blueprint in the document and the slides that you received, this is an active link and it will take you to the focus areas of where we are as a country. And I want to point out goal number 1, increase access to and coverage for comprehensive high quality maternal health services. 2, ensure those giving birth are heard and are decision makers and accountable systems of care. 3, advance data collection, standardization, harmonization, transparency, and research. Goal number 4, expand diversity and the perinatal workforce. And goal number 5, strengthen economic and social supports for people before, during, and after pregnancy. And all of this has been because of the extensive focus and following the data. And that is so important for where we're going to measure and see improvement. So I want to pause here just for a moment and ask everybody this poll. Are you familiar with birthing friendly? And you have a range of answers from very familiar, somewhat familiar, and not at all familiar with birthing friendly. So while you are answering that, we'll have about a 30 seconds pause while we collect your information. So please take your time and, just be honest. No judgment here if you do or if you don't. And again, while we're compiling answers, the reason I wanted to ask this question was this was another question that I asked to a very large audience. How familiar are you with birthing friendly? And again, I was pretty surprised that very few hands went up. And again, this is bedside clinicians, clinicians who actually deliver care to uh, obstetric patients. And so here we have the answers. You can see that only 14% are very familiar, and the majority of us are somewhat familiar, but the most percentage are not at all familiar. And in my world around patient safety and improvement, we are really looking to the federal government, and the federal government is the one that made this designation. I'm going to go into it here for just a moment, and talk about what birthing friendly is. But at the end of the day, they came out with this new process in 2020. It was the Biden-Harris administration, and really putting forth a lot of focus and dollars on correcting this crisis and putting in processes that are going to make a difference. And the very first step was that any hospital that delivers babies had to attest that they would participate in national perinatal collaboratives and adopt evidence-based guidelines and practices. And that, you will hear, is really important as we move through this presentation. And again, what happened is in 2023, the goal of all this was to publicly report so that birthing people were informed about the hospitals where they go or where they choose to deliver their babies, and they would be put on display at the Hospital Compare website. Over 2,000 birthing hospitals did respond, so very little burden to the hospital to say, yes, we are working in a national collaborative, which mostly was the AIM project. But were they actually, and have they really been making changes and changing culture and working with providers? And that is, TBD, yet to be identified, but we know we still have a long way to go. But the good news is public reporting and more information is going to be coming around that. In addition, American Rescue Plan, this has been all about expanding Medicaid to a full year. If you don't know this, Medicaid is for women and children largely, and about 43 to 42% of all babies born in the U.S. are born under the umbrella of Medicaid. So we as states have a stake in the health of the country and how care is delivered. We fund it, and we have to care, and we have to pay attention to this population. But the goal here was to expand from 42 days to 365 days, and we are making really good progress. And the reason is because a big portion of the maternal harm and deaths that occurred after 42 days. So we have been missing, because coverage ended for a big portion of birthing people in this country. So to recognize that, expand that, and there's still a few little straggler states, but we are getting there, and that is really exciting. The other thing, I think this is important, and then I'm going to jump into our maternal mortality report because I want everybody to understand why we should care. What the maternal mortality review committees were established in many, nearly almost all states, but it gave states a time to really dive into their own data and to understand what, excuse me, were the causes of death in your state. And you can see on this little pie chart here, the donut chart, 42% attributed to patient factors, 35% attributed to provider factors, 22 to systems of care. But if you look at over here at the narrative and the dot points of what that actually means, and I'm particularly for provider factors, this is where I spend a lot of my time, which is hospitals and health systems, doctors, nurses, midwives. What are we doing at the bedside, and how can we transform and improve outcomes in maternal morbidity and mortality? Again, mortality, women who die related to their pregnancy, and morbidity, they suffered harm or they have a chronic illness and it exacerbated and got worse. And now you actually have maybe potentially a more of an issue, and we have more maternal morbidity now, and we're really diving into that data as well. But failure to perform a clinical assessment that is completely against standards of care in this country. Wrong or delayed diagnosis, delayed treatment, lack of communication between providers and patients. Think about the care system we have, from acute inpatient to outpatient to community service. We know we have to do a better job, and that's where a lot of the drop off happens when it comes to socially vulnerable populations, racism, Black and brown women, and other minority populations. But again, when you look at the patient factors, absence of social support systems, inability to recognize and need care, disruptive relationships and housing, lack of adherence to medication. Again, this is not about pointing a finger and saying we can't do anything because the patients are difficult to manage or treat. It's about what can we do to shore this up. And if we know we have alcohol, drug use, poor social situations, that just means they're more at risk for death and harm. And again, where the mother goes, the family goes, or the birthing person, the family. So this is why it's so important to our country. Think long term. I thought this was just really interesting and pretty much hot off the press, May 14th of 2024. Maternal mental health with the George Washington University report card. This effectively looked at payer data, HEDIS data, and said that the US improved from a D to a D plus on grades around maternal mental health report cards. And again, just not acceptable. Over 600,000 mothers are affected every year. No one is immune. Women of color are more vulnerable. 50% of mothers are not diagnosed by healthcare professionals, and 75% of mothers never get the treatment they need. It's a very costly, in the billions of dollars to the US health system. And we've got to do better state by state. So let's jump into our report. This is a really exciting report, something Relias is very committed to, and the background is we examined current perceptions among obstetric care providers and nurses, clinicians in the acute and behavioral health care areas about maternal health care practices and their organizations. We surveyed over 700 nurses and providers, physicians across clinical behavioral, across the concerns areas of clinical behavioral and social maternal mortality and morbidity risks. So that's why it's so important, because we are getting the opinions of people who are caring for this population. And I think about it this way. They are the front line. And as leaders in healthcare, we have to listen to what they're telling us. The demographics of the survey, again, the majority were registered nurses, but you can see providers, certified midwives, clinical educators, practitioners, physician's assistants, anesthesiology, and even some med students. The key findings, 5 key findings, what we identified: gaps in maternal health practice in knowledge and priority. We're going to go into some detail in each one of these, but I wanted to just kind of go through what the 5 were. Maternal clinical risk prevention practices vary significantly. Maternal behavioral health practices are lacking. Racism, implicit bias, social determinants of health recognized as maternal risks. And e-learning is the most used, most effective training modality for behavioral and social maternal risks. So finding number 1, gaps in maternal health practice knowledge and priority. The survey participants reported that their familiarity with their organization's practices related to maternal health revealed substantial room for improvement in practice knowledge. So again, this goes back to using evidence-based guidelines and protocols. Only 59% of clinicians surveyed said they were very or extremely familiar with their organization's maternal health practices. Again, what we are focused on, and in this care area, obstetrical care, labor and delivery, postpartum care in the hospital is very protocolized. We have protocols in every single one of the high risk areas, and that think about it this way: obstetric hemorrhage, maternal sepsis, hypertensive disorders of pregnancy, preeclampsia, eclampsia, significant protocols from all the leading associations, physicians, nurses, midwifery practice, and look at these numbers, and we've got to do better. 42% were very familiar, 32% somewhat familiar, so we can do better here. In terms of priority level, providers and clinicians' attention to focusing on this problem in their own organization didn't really, there's again, near 50% at constant attention, but 12% minimal attention. And so you can see the variation in how these 750 clinicians process this information. Findings number 2, maternal clinical risk prevention practices vary. 6 high-risk clinical areas, and you already heard me kind of run through them, around prevention are hemorrhage, hypertension. These are the common reasons and why women have a adverse event, harm, or a death. And this is where we can absolutely make a difference and work on reducing care, variation in care. For only 3 of the clinical risk areas, over 60% of the participants reported they always use evidence-based protocols. And so you hear me talk about evidence-based protocols. This is what drives patient safety and improvement. And we have to leave room for medical decision-making. But again, that's a very rare and a much, much smaller percentage of the patient population and clinicians. So this is a huge area of opportunity of improvement, and it can be addressed through education and training and adoption. And this is on the hearts and minds of clinical leaders across the country. This is something we hear all the time. How can we engage our providers? How can we get private attendings to adhere to our hospital quality? And we are seeing the best practice is this is just how hospitals operate. If you want to deliver at our hospitals, you have to get on the bus, and the bus is patient safety and high reliability. And we need some more pioneers and brave clinical leaders to challenge some of these long-held beliefs that our patients are sicker, our patients are different, our patients, or I'm a provider, I'm a midwife, I practice the way that I practice. We respect that, and nurses need to do their fair share too. But this is a team-based clinical practice area, and we have got to do better in this area. You can hear I'm pretty passionate about this because this is something I spend my career focused on. Again, here we did the Likert scale of always to never, frequency of protocol use. And again, I'm not going to go through each one of these. You will have these slides, but you can see the variation. And in some areas, the good news, you know, where the highest percentage is in the always category. But when you start seeing usually around 8, you know, you're at around the 20 to 30%, and that's not okay. And then sometimes, and then rarely. So this is the opinions of the care team. So we really have to think about what we're going to do as healthcare leaders and go audit our own team and make sure we shore this up. So we want you to respond in the chat about this. Does your hospital, department, or clinic, depending on where you work, do a good job in screening for maternal mental health? So we'd love to see your comments in the chat on that. And then, I can see a little bit of this. Don't be shy. We'd love to hear your, okay, I love that. I'm seeing the PHQ-9 and the Edinburgh. That's fantastic. There's more, and I know you guys can start to see some of these comments too. So keep that going so everybody can see and comment. And then I'm going to keep moving forward, but this will be a really important part of the conversation as we, continue on, and we'll definitely get back to this part. But the finding number 3 is that maternal mental health screenings and follow-up are not standard. And what's been interesting, if you look at the federal data, the CDC data, etc., this is where we found after 42 days, this is where maternal mental health crises and the sequelae from not being screened, diagnosed, getting a treatment plan in place, where we start to really see the harm over time. And again, we asked about efforts related to maternal mental health and found that behavioral risk reduction practices lagged compared to the clinical practices. Again, I've been doing this work for a long time, and I will tell you, prior to COVID, maternal mental health was not really on top of mind when we were looking at maternal mortality and morbidity. We were very focused on the protocols and reducing variation in the clinical setting on the clinical factors like hemorrhage, hypertension, excuse me, maternal sepsis, etc. So coming out of COVID and the new data set and the focus on this maternal mortality crisis lifted up maternal mental health, which is huge. I actually have lost a family member to a complication from peripartum depression. And so obviously something very personal to me, but everywhere I go and people that I talk to and where I present, someone has a story. If it isn't yourself, it's a family member, a child, a relative, a daughter-in-law. Somebody has managed this and experienced it, and that time of their life is probably one of the most hard times of their life, and I know everyone can relate to this. This is very relatable. So it's time to elevate this and start creating that standard of care. In the survey, 57% of clinicians said they always conduct mental health screenings. Only 50% screen for substance use disorder. Only 72% reported their organization usually or always conducts these screenings. And so you can see there's so much variation here. And again, that over the 700 people that we surveyed come from all different, across the care continuum, from the acute care side to the behavioral health side, and even in the hospital and health system side, an inpatient behavioral health, social workers, etc., and community clinics. So a big opportunity here to really double down. And if you take anything away, I think obviously looking at your protocols for clinical and mental health is really going to be important, and understanding how you are doing as an organization. Maternal behavioral health risk reduction practices. Again, we went on the Likert scale from always to never. And again, you can see the majority, if I think about this at the 50th percent, sometimes and above, it's better, but we still have a lot of variation. So 50% is not good enough. The ACOG, as an example, initially had a standard of care that said a pregnant person should be screened at least once during their pregnancy. And now we've moved to serial screening. So you have to think through your own organization's protocol and imagine that every time you interact with your patient, we have to be thinking about this. We can't be jaded because all the other 20 people that you saw before this one person said they're fine. You have to be consistent and create that standard of care, because this is where these birthing people fall through the cracks. And that's what we have to shore up as a country. Behavioral maternal risk reduction practices used at participants' organization. Again, 68% standard assessment of mental health or substance use, 100% of patients screened and using recommended assessment tool. 63% patient education and resources, 51% connecting patients with resources prior to discharge or holding patients for treatment if needed. Think about that for a second. If you have somebody and you use those standardized evidence-based tools for screening for depression, suicide ideation, substance use, or other social risks, and you don't have a treatment plan in place, or they're not screened by a social worker or advanced practice clinician before they go home, do you think it's going to get better, or it's just going to continue to spiral down when they get home and all of this support that they had in the hospital is not there anymore? And if they're in a situation where they don't have community resources, where, rural health in particular, we'll talk about that, but there's more risk factors there. So you have to be thinking about this in a much more global and holistic view than we ever had before. We don't have the numbers of social workers and health systems like we used to. And we don't get those standardized home visits unless you're in a commercial health plan like we used to. And a lot of that is coming back into play. Remember in the 90s and HMOs where it was for me when I had my babies, I'm old, but I had 2 home health visits for every single one of my deliveries, and it made such a difference. I was a new mom, I was unsure, and just having somebody come home and let me ask questions and check on me and shore me up and give me the confidence I needed. And I'm a clinician. I had resources. Imagine somebody who doesn't have that. So you have to put yourself in their shoes and really go the extra mile. Finding number 4, racism, implicit bias, and social determinants of health recognized as maternal risk. We asked about maternal mortality and morbidity prevention efforts related to these factors, and a lot of issues around here. We've talked about this. This is where we're spending, the states in particular are spending a lot of time identifying and looking at their MMRC data, the Maternal Mortality Review Committee data. And I hear from all different type of state leaders in the different states. Some are clinical around hemorrhage and hypertension. Many are around implicit bias, social determinants of health, and racism. And so that's where we have got to create the standard of care in your community, and where acute care meets community care. And we really have to close the gaps on that transition, and hospitals have to care. Not that they don't, not that you don't, but there has to be some more hard wiring to close the gaps from discharge on the hospital to home, and that ongoing holistic approach. Again, nearly one fifth of clinicians surveyed did not perceive racism and implicit bias to be a factor, and that's just not accurate. So we have to educate our clinicians with these data and fact to let them know and raise awareness that these are factors that play into the maternal mortality risk. Although 30% reported always screening for risks related to social determinants, treatment and follow-up were inconsistent, with only 60% following any standard protocol. I would say I've seen a lot of movement in this area, but it's still not enough. So it's time to really double down and really create that holistic approach. It's a new standard of care that we have not paid attention to in a very long time. And again, perception of maternal health social risk factors. You will have these slides. You can share them with your team. Again, we have from the Likert scale, a severe issue to not an issue at all. And we have, I mean, think about that. To what extent do you perceive racism or implicit bias to be a factor in maternal mortality and morbidity? And I'm pretty surprised by these results. If you look from a significant issue to a minor issue, this does not reflect the findings in the national data and the state level data. And if this is a surprise to you, again, we have to do our research, we have to raise awareness, we have to educate our teams on the issues. And again, go back to what is birthing friendly and the White House blueprint. This is millions and millions and millions of federal dollars are going to address these issues. And so we have to do a better job. Finding number 5, e-learning, the most used, most effective training modality for behavioral and social maternal risks. And again, keep in mind, Relias, what are we? We're a healthcare education technology company that is focused on workforce readiness. This is our sweet spot. This is what we excel at. We bring the evidence-based guidelines and protocols to your teams. And so we care about adult learning theory, adult learning science. What are the best modalities? How are clinicians learning? We keep our finger on the pulse of all the modalities and what's happening to our workforce. Look at the nurse workforce, look at providers, look at obstetric providers. We have healthcare deserts in rural healthcare. Many women, birthing people are driving hundreds of miles to get to the right level of care that they need. And so how can we reach the masses of the workforce through computerized technology-based learning? Wherever you can get the internet, you can get access to the evidence-based protocols, education and training. And this is, here to stay. We're not talking about old style learning where you sit in front of a computer and click, 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 click. We're talking about something more engaging, and we continue to refine what we're doing. It's not just us, it's a movement afoot in the industry and the world and healthcare. But I say this because I want you to know it's something we care about deeply in making sure we're not only delivering the right education, but it's engaging, it's digestible, you can access it, it's at the point of care, and those are all things we care about. We are also growing our content in the behavioral health side and the social side. We're excellent and have been excellent on the clinical side, but also following the data, and that's something we're building out, which is really important. So here are the training modalities. If you think about all the different ways, so e-learning, and e-learning can have lots of definitions. So we try to boil it down to some very specifics, but like blended learning, simulations, team training, virtual reality, augmented reality, assessment-driven learning. And at the end of the day, many of these can be all related, but I always think about it this way because I've talked to a lot of clinicians and nurse educators about this, which is the traditional classroom style learning is still one of the primary ways we deliver learning, and it's one of the least effective in terms of creating salience, and salience is what creates memory and longevity in a knowledge object and maintaining that education over time. And so we have to think through, and at times instructor-led education is very effective, but it's got to be part of a blended learning modality and approach. But again, you can see clinical risk topics, behavioral risk topics, racism, implicit bias, and social determinants, and think about what you're doing and how you might augment what you're currently doing to be more effective. I mean, you saw the data, you saw that people have significant variation around, even think about the social side and the racism side, and we know that that's a huge component of the maternal mortality rates in our country. So we've got to do a better job, and that's something we're advancing. Again, a lot to read here. I'm not going to read through this, but I would encourage you for the most beneficial training factors for clinical risks. The top beneficial training factors were all close, but 4 attributes selected by 50% or more. I like that it is interactive. It keeps me interested. Or implicit bias. It is most appropriate or relevant for my role. Again, on the behavioral side, only 1 factor was selected by more than half of the participant. It keeps me interested. The top training for racism or implicit bias was most appropriate or relevant for my field or role. The interesting thing about this is we all have natural bias and we all have to go through training. Some states have made actually changed their laws that if you care for pregnant people, you are required to take implicit bias and social determinants of health education every year. If you're not doing that, you must consider it. And then the top training factors for social determinants of health was most convenient, fastest, or most efficient, and easy to use and navigate. So we're taking stock of all of this. Again, but you can see the variation. And we're working to help you address this with your workforce. So some key takeaways, and then we're getting close to the end here, but the key takeaways: gaps in maternal health practice, knowledge, and priority. 2 things here: leaders can gain important insights by assessing how well their organization disseminates maternal health practice knowledge, and for that fact, critical thinking to ensure clinicians are confidently striving to prevent maternal harm. We want all clinicians, of course, this goes without saying, to be at the top of their game. Think about our workforce. We have an ever-changing nursing workforce, and the dynamics of nurses leaving the field is at a higher rate. We do really have an acute hospital-based nursing shortage. And again, we've been talking about this for some time, but you can start to see the trickle down impact to patient care. And the most vulnerable members of our society are birthing people and their babies. So we have to do more in this space to make sure we're growing competency. They have access to the evidence-based guidelines, and we can keep up with that changing dynamic frontline workforce team. In addition, you can reinforce as leaders maternal mortality and morbidity prevention as an organizational priority. It should be part of your perinatal safety dashboard. You should be capturing this data. And if you look at the pure fact that many of the frontline clinicians are not even aware of what birthing friendly is, that's something typically likely managed at a senior level leader in the organization, that it should be information shared and more transparency about what your organization is required to do around this issue. Another key takeaway: maternal clinical risk prevention practices vary. Healthcare leaders should assess whether their clinicians providers effectively address risk areas. Again, evidence-based protocols and guidelines, personalized learning, personalized education, more immersive type learning modalities, more collegiality, teamwork, and communication among the care team. We cannot have providers sitting outside of the bedside team in a hospital. We have to come together and find more ways to do that. Again, providers have to be educators as well. We're in a different time, and Again, the hospital is really needs to kind of pull that all together. Ensure your organization's clinical care protocols support consistent attention to preventing harm and using evidence-based guidelines. Another key takeaway, maternal behavioral health practices lacking. I think a key takeaway here, you have to remember, um, uh, maternal mental health is maternal care. So the clinical side and the behavioral health side. It's that holistic approach, and we've kind of gotten away from that. We've become very compartmentalized, and we have to reach back out into the community. Nurses that discharge, social workers, everybody needs to know what this person is going into when they are discharged to their home environment, and we have to help support them, make sure we're following up with them, routinely screen for mental health risk, treatment follow-up, and make sure that we're getting better on consistency. The other one, so important, we talked about this quite a bit, racism, bias, social determinants of health recognized as maternal risk. So we have to put that in our education and training and be talking about it and not be shying away from it. You know, nurses, bedside nurses are not often trained in these areas, but we have to think about how we're going to do a better job of doing that. The nurse spends the most time with the patient, so it can't just be a check the box in the electronic medical record. It has to move to some level of protocol and action to make sure they're getting evaluated. And if they're getting evaluated and they're a positive for risks, what's the treatment plan? What's the follow-up? What's the diagnosis? And repeat, rinse and repeat, right? It's not going to go away. And again, training, raise awareness. Healthcare leaders are responsible for making sure their teams have competency and are growing that competency and continue to refine the competency, and that behavioral and social risks matter, and expanding your e-learning offerings and mix up how you're doing education and training. We know everybody is maxed out on time. We know it's a consideration, but let's all talk about this and let's continue to solve this together. So we're at the end of the slides. Thank you guys so much. We will have a little bit of time for some Q&A. But at the end, I just want to kind of give you this picture, the holistic maternal care standard of care that needs to be created. I feel like, because I've been in this space where the pendulum swings, right? We were doing managed care, and now it seems to be a little bit less of a factor in our healthcare system. But the social and maternal mental health matters as much as the clinical risks. And so that's that holistic model. If you think about race, ethnicity, health insurance, education, the clinical sources, the non-clinical sources, depression, anxiety, postpartum, substance use, we have to look at all of this in a very holistic way. You need to know your patients, you need to know your community, you need to know your data, you need to integrate universal mental health screenings and coordination of care. Again, we moved to a model of case management, but case managers are not, they're coordinating care. They do a good job, but again, think about the prioritization. It's not always, we've left that social model and we got to pull that back in. Take a closer look at the late postpartum period after 42 days. Continue to follow through all the way to that first year. And honestly, if somebody's still representing risks, they still need to be followed even after that 1 year. That's on us. Know your communities, expand the outreach services, and educate your staff. So thank you for your time. You can connect with me on LinkedIn, and I would love to stay connected with you. Also, you can download this report, the Maternal Mortality Morbidity Prevention Report. I think this is just an amazing report. It substantiates and confirms what the data is telling us, and these data are real people and their stories. And there's so many heartbreaking and preventable stories of death and harm. And we have to listen to the front line, and that's what this report represents. And I will turn it back over to Julia.
Thank you so much, Laura. That was fantastic. And you've given us so much to chew on and think about and act on. So to those of our listeners, I see some of you are submitting questions. I would encourage you to keep doing that through the Q&A pod. Preferably not the webinar chat. Q&A pod is easier for me to handle everything coming in. So I'm going to try to group some of these by topic just so we can get to as many as possible. So I want to start with thinking, so at the beginning you shared the data about how much of maternal morbidity and mortality comes after labor and delivery, and how we really need to be thinking about that. But, as healthcare professionals, a lot of folks are chose to focus on, the clinical setting, and labor and delivery nurses train in labor and delivery. So how can healthcare organizations apply those like quality improvement and patient safety approaches to improve postpartum outcomes long after new moms have left the hospital?
So the question, so I'm sorry, Julia.
No, that's okay.
I was reading another question, but please tell me that one more time.
So thinking about, that so much of maternal morbidity and mortality comes after discharge, after baby is born. How do we help our healthcare providers think about quality improvement and patient safety to prevent morbidity, mortality during like that extended postpartum period when most death happens?
Yeah, that great question. And it's, that's the thing. It's the continuum of care. That birthing person is going to go back to see a provider. And there is a lot of great practice happening across the country where there are provider groups, physicians, and social workers that are focused specifically on maternal mental health, and clinics that are popping up in some of these they're more in big cities, large academic teaching centers. But it has to become part of the narrative, with the provider as the primary care for that birthing person. We may, I see many people moving the first postpartum visit sooner, not waiting till 6 weeks. So that's important. And we have to educate the clinic office, the primary care, the obstetrician's office team on, as part of that care continuum. We also have to connect with, and again, thinking about people across the social spectrum, and the risks around social determinants of health in the clinic setting, in whatever environment, whether it's rural or community or inner city, urban life. It is about, I'm going to just say this, being dogmatic, and we have to change the standard of care. So it is going to have to take some action around raising awareness, education and training, gathering data, and the birthing friendly piece. The more data is going to be required that your hospitals contribute to the feds, because they want to understand where are the hot spots, where are we seeing the biggest gaps in care. Not again, definitely around the maternal deserts, but also around inner city where you may have care, but can somebody get to the care? So more data is coming, and providers are going to be held accountable, and hospitals are going to be held accountable for their data and statistics.
Great. And we had a few questions come in about birthing friendly, like what really is it? How does that change the kind of care is provided? And have you found that is it a preventive factor from some like rural hospitals for continuing to do births? Like what has the impact been?
Yeah, I saw that question. I think it's really insightful. But I would say this. I don't think there was a connection to the closing of delivery sites, because it's really more about a shortage of obstetricians and qualified clinicians, and risk, and not having the right resources. So one of the things I will kind of raise to get everybody thinking about this, but your maternal levels of care that are now being uh, evaluated by the Joint Commission, but it initially, it was ACOG and A1, but it was very much a collaboration. Those maternal levels of care are ACOG, A1s, the Joint Commissions, and the US hospital and health systems approach to making sure that birthing people with the most risk get to the right level of care. And hospitals have to be certified. If you're a level 4, you have to have the services and care. You have to take care of the most sickest and those birthing people that are at risk. So if you have preeclampsia, if you've had a hemorrhage before, if you have some kind of clinical or depressive state or behavioral health diagnosis code, the goal of that maternal levels of care is to direct that birthing person to the right level of care. So to me, for right now, that's one of the best movements that we have going on, because it's basically attesting that those hospitals have the certified clinicians, the competency to take care of the right level of patient. And one of the most scariest things is to have a hospital, and some hospitals don't even claim that they are a delivery hospital, but they birthing people show up there and have babies there because they can't make it to a hospital. So we have to figure out how to educate these critical access hospitals and areas where they have family practice doctors who aren't doing deliveries. More telemedicine is going to come into play, and other models of care are being developed and tested. So I would say, again, know your area, know your communities, and be creative. There are a lot of federal funding for block grants where you can participate as healthcare organizations and get funding to initiate a program or connect to a program. So I know that was a long answer. I tried to fill in
Yeah.
a lot, from what I'm seeing here, but that is, I think, something that's really important from a health hospital and health system perspective, are those maternal levels of care. And what the action that I see from the hospitals is they're shoring up their gaps in competency so they are prepared to manage based on what their level of care is. The worst thing we want to do is say we are one thing, and then you get a patient that needs that level of care and you're not prepared. And so that's a disservice to that population. We do what we have to do, right? But at the end of the day, we can do better, and we know that there's a path to make that happen.
Wonderful. And I really appreciate the thorough response. And I know we could talk about this for days, but we are at the top of the hour. So Laura, I would just want to thank you for sharing your expertise with us. This was fantastic. We really appreciate Relias and their continued support of the AHA. I just really appreciate you being here and sharing the survey results with us.
Thank you so much. We really, really appreciate AHA and all of you for everything that you're doing. Thanks for joining us
Yeah.
today.
And thanks to all of our participants. You have the slides, and we'll be sending a follow-up email in the next few days. So thanks so much, everyone, and enjoy the rest of your Wednesday.